today we will start with luteal phase. We will talk about luteal phase in detail. I hopefully will cover in 1 hour. So first thing in our practice, we should be having this motto. Let's believe in chasing excellence every day. You cannot say that I'm working for last 2.5 decades, 3 decades, 2 decades, and I have given so much, so one day I can be relaxed. No, for that patient, it may not be good. And that's why we have to. We will be talking today the luteal phase support in IUI cycle, IVF cycle, what works, what doesn't work, what we should be doing. So I'll be briefly telling you what is luteal phase, what is the place of a luteal phase support in a different ART programs, different drugs available. We will compare the efficacy of each, and we will evaluate the different routes and types of progesterone administration, because so many progesterones are in the market, from oral to vaginal to intramuscular to subcutaneous. Which routes is better, what we should be giving, whether we should be giving combination of all or we should not be. Today, I'll be taking you, and also when we will start the luteal phase support and when should we stop the luteal phase support, the most lingering question in everyone's mind. I think if I address these questions, we will be covering the topic good. So luteal phase, it reflects the lifespan of a corpus luteum. When back in 1975, Baird et al., they have told. So it is defined as the period from occurrence of ovulation until the establishment of pregnancy or resumption of a menses after 2 weeks. So the corpus luteum is the gland, that is the temporary endocrine gland in our body, which works only for 14 days, and it forms from the remnant of a ruptured follicle. And it is the major source of a steroid hormone, that is the progesterone and estrogen formation. Maybe up to 40 milligrams of progesterone per day can be formed with it. So once you understand luteal phase, you should know how the hormonal milieu works in this. So the luteinizing hormone and the follicular stimulating hormone FSH goes down, while the estrogen and progesterone. But you need this LH to get this estrogen and progesterone, so which is very crucial in pregnancy. So if you need to have a successful implantation, you need to have an adequate milieu of the estrogens and progesterone. So it will help. If the hormonal milieu is normal, it will form a beautiful, functional, morphologically and physiologically functioning endometrium, so that there can be an endometrial embryo healthy dialogue, and there will be a good immune tolerance. Now, as I said, LH play a very important role. First, it is totally responsible for the steroidogenic activity of corpus luteum. It also causes upregulation of the growth factors, VEGF, FGF2, and other cytokines, which are all very important for the implantation and for the healthy dialogue between the embryo and endometrium. And it also causes stimulation of LH receptors in the endometrium, which also then will help. What other things it does? Though this goes more of a theoretical, one should know that LH will downregulate the estrogen receptor and thus suppresses the inhibitory effect of estrogens on integrins. It will help us, as I told you already, in EGF and other factors. HOXA10 implicated in regulation, its expression also is improved. So progesterone and estrogen progesterone and the LH hormone plays a very important role in maintaining that. Now, when do you call inadequate or luteal phase insufficiency or inadequate functioning of a corpus luteum? It may be that the progesterone levels are decreased. The action of a corpus luteum may remain for 14 days, but the levels of progesterone are not good, or the corpus luteum, that is luteal phase, is reduced. So decreased duration of a progesterone or decreased number of nuclear progesterone receptors in the endometrium. So the progesterone in the body may be secreted, is normal, but there are no adequate receptors in the endometrium, and that's the reason the progesterone effect is not seen. So any of these three will be causing a progesterone or a luteal phase insufficiency. So luteal phase insufficiency, when can occur? It can occur in natural cycles. It can occur in a stimulated cycle, gonadotrophins with or without GnRH analogs. So actually, I'm going to go in a evidence where CC or aromatase inhibitor stimulated cycle, probably you don't need a luteal phase. We just give it empirical. While in gonadotrophin cycle, it is much needed. How do I diagnose the luteal phase insufficiency? Very difficult to measure, but if you measure the luteal phase duration, so if you know you are monitoring the patient, you know when the follicle has ruptured, and if she did not conceive her first day of her menses. Now, if she was not on any luteal phase support, it will be the effect of estrogen and progesterone, which is secreted from this corpus luteum, and you can measure the luteal phase. Or you can assess the progesterone. The best way to assess is on 21st day of a period in a lady who has a 28-day cycle. Or very rarely, which none of us do, luteal phase biopsy, do it on 21st, 22nd, 23rd day of a menses and see whether the progesterone defect. I will add on to this is by the sonography. When there is a progesterone effect on this endometrium, the lining become echogenic. When it is a follicular phase, when it is only estrogen, it is a trilaminar, beautiful lining. Only you get the trilaminar picture. While anechoic, black in between the three lines. While when the progesterone effect is seen, everything becomes echogenic, compacted, and that itself will tell me on a sonography that the progesterone effect has started. Now, there is lack of reproducible and reliable diagnostic tests to detect LPD. Luteal phase deficiency, luteal phase progesterone measurement or seeing the effect is one part, but in this patient, there is a decreased luteal phase. There is no one diagnostic test as such approved. And the correct approach to the treatment is the identification and correction of this. So I may start thinking if the patient has low level of FSH, abnormal FSH-LH pulsatility index, or if the patient is on the GnRH analogs, or if I feel that they have taken a gonadotrophin and they have undergone luteolysis, there can be, we can think. So there are, as such, many more tests you can think about and you can work on it. Now, what are the strategies? I'm just trying to take out this bar. What are the strategies to correct the luteal phase and treat? Very simple, two ways. Either you improve the follicular phase. You improve the follicular phase, automatically the luteal phase will get improved. You improve the luteal phase directly by the progesterone supplementation. So these are the two ways. And why it is important for us to have an adequate progesterone? Because the endometrial receptivity will be present only when the progesterone is adequate. Endometrial receptivity, it is a self-limited period in which the endometrial epithelium acquires the functional and transient ovarian steroid-dependent state. We all know that there is an implantation window which allows the implantation, the first phase of a blastocyst adhesion. And decreased endometrial receptivity is major cause of a low implantation, and the decreased endometrial receptivity may be because of the luteal phase defect. So to prepare the endometrium, to achieve the ART success, or even for the natural cycle, all this is important to have a good progesterone. Now, what are the reasons why CC should cause a luteal phase defect? Now, one way you can think that clomiphene citrate, it occupies the hypothalamic E2 receptor for several weeks. So there is a receptor downregulation, and that's why there is a progesterone receptor block. Markedly high level of E2, it might give 2 follicles, 3 follicles. When there are very high level of E2, the E2 progesterone ratio abnormal will cause a luteal phase insufficiency. There will be a glandular stromal dyssynchrony because of that, and also the luteolytic effect of the corpora lutea and antiestrogenic effect of the on the endometrium, even in the follicular phase. So you can think of these may be the various causes why clomiphene can also give the luteal phase defect. But what does the evidence says? Evidence says Luteal phase defect is seen in IVF and gonadotrophin stimulated cycle. So what happens in gonadotrophin stimulated cycle? Definitely supraphysiological estrogen, resulting in deficient LH in the luteal phase, because high levels of estrogen will again cause a negative feedback. At the same time, decrease LH level. This is what one, supraphysiological E2. Second, use of antagonist or agonist. So we have done a hypothalamic suppression of a LH, that is by use of analogs, or you have given a SEG via short loop. It can cause internal endogenous suppression of a LH. And in ART cycles, when we aspirate the follicles, we aspirate not only the oocyte complex, but we aspirate lot of granulosa cells of the that follicle or that corpus luteum, and that itself can cause a luteal phase insufficiency, because steroidogenesis will get hampered. So once you understood why in stimulated cycle, then let's start thinking about the implantation. So we all understood that clomiphene citrate or a natural cycle, it may not be needed. The evidence doesn't tell us. It is we who give it empirically, what definitely required in gonadotrophin and GnRH analog. But in a CC cycle, sometimes you find patient responded with 5 follicles. Young patient, young PCOS with 50 milligram. If you know, then you shouldn't think yourself, oh, 5 follicles. That means it has a supraphysiological E2. We all stuck in mind with the OHSS, but we also should think about luteal phase defect in these patients. So mainly, otherwise, natural cycle and CC cycle, we give a empirical. Now, if we talk about empirical, because both, we don't know actually what is happening. We want result. We are here, the government or the Mediclaim doesn't pay. So we need to have those luteal phase well balanced for implantation. And that's why sometimes thinking that both of them are important, we give them. We also know that endometrium is very sensitive to decreased steroid level, and there may be altered A2 P4. That's why we give it. Sometimes there may be a delayed endometrial maturation, and we just want to improve it. So but evidence doesn't allow. No RCTs have said that you need to give in CC. But if you see few of this, where the gonadotrophins are used, the systemic meta-analysis, supplementation of a progesterone definitely increases clinical pregnancy rate and the live birth rate. If you see, this is another systemic meta-analysis. With clomiphene, they said no benefit, but with gonadotrophin, or if you add gonadotrophin with the CC, there is a benefit. And the same meta-analysis is supported by other journals also. So luteal phase support in IUI, another randomized study. All what they are saying it that luteal phase with the vaginal progesterone did not increase in a CC and HMG in a younger patient. So this, why I have taken this study, because here they worked with the age of the patient. They say even in younger patient, even if you have used gonadotrophin, there is no need of luteal phase support. But if it is after 30 age, then the gonadotrophin support is needed. So apart from just thinking about, so if my patient is of 33 or 34, and even if she is on a CC simple, I will still think of giving, because this is what this evidence says. And in ART cycles, absolutely. A condition of insufficient progesterone exposure to maintain the normal secretory endometrium and allowing embryo implantation and growth is the main. I told you again and again, once more, I revise, high number of corpus lutea directly itself can cause defect, supraphysiological levels of estrogen, negative feedback action on the hypothalamo-pituitary, especially the LH, and inhibition of a LH can cause a luteal phase. Now, use of progesterone in IVF, meta-analysis. Yes, Every study has proven that the progesterone, I don't know this study, when the Cochrane has presented this study, I felt, are there people who did not give a progesterone support? In India, no one will do because they are self-sponsored cycles. But there are people in a fresh cycle, they did not give thinking corpus luteum will work. But they have found that the group with the high progesterone, with the normal progesterone, the live birth rate, clinical pregnancy rate, or the ongoing pregnancy, all are important. So we understood now that the luteal phase play very important role in a clomiphene cycle. When can I give? If I find supraphysiological, many more follicle, or if the elderly patient. All gonadotrophin stimulated, I will give, and all IVF, fresh or frozen, I have to give. Now, which are the drugs I should be? Progesterone, yes. Can I give a SCG every third day, 3 to 4 doses in those 15 days? This is also one regime. LH, people have given, I'll come to it, why we should be giving, and the estrogen. These are the 4 drugs which are spoken very high, though the role of estrogen evidence doesn't allow, while progesterone, various. Now, our next problem with progesterone is we do have a dydrogesterone hugely. And now so many companies, I believe 15, 20 companies have come up. Why so much? Because it is a very important molecule. The patent of one company got over. And because it is so important, the dydrogesterone, it is so easy to take. The evidence has proven it. I'm going to show you all the references that the many companies started getting a oral progesterone. Vaginal, micronized progesterone, yes. Intramuscular, yes. And subcutaneous. I have used subcutaneous quite a lot because intramuscular is so painful. But now, since the oral progesterone efficacy has been proven so well, probably I'm shifted completely with the oral progesterone. Then, oral progesterone, which are the drugs? Oral micronized was available for a long 800 milligram dose. So you can give 400 milligram BD or 200 milligram QID, or you can have a dydrogesterone. Now, when it was a micronized progesterone, I never have given orally because of obvious its disadvantages. One is liver bypass. So the availability is low. Second, it gives a dizziness, sedation to the patient, and it is not so well tolerated. Efficacy is not so good, but vaginal micronized, yes. But when dydrogesterone twice a day, I will show you the Lotus 1, Lotus 2 trials when they came in, and it was not only not inferior, but equally good. It has proven majority of the ART consultants have gone to 20 milligram. Let me tell you, I give 30 milligram a day. Vaginal micronized progesterone or the gels are available. One can use a once a day gel, that is the advantage, while the micronized pastry, maybe you need it twice. And then the oral estrogens or the estrogen gel, whichever patient is comfortable to take it, one can think about. GnRH agonist. Now, in which cases we use GnRH agonist? It is used in day 6 of a oocyte retrieval in a fresh embryo transfer, and they have found that this LH works in the endometrium. I'll come to it later. Now, intramuscular and vaginal form. When we are using a lot of intramuscular, we have used a lot in for first 15 years, from 2000 to 2015-16, lot of injectable progesterone. Why we wanted or we waited for a long to shift to it? It was very painful. Occasionally, it has caused sterile abscesses. Occasional allergic reaction. You need a deep intramuscular. You need a nurse, husband, someone to give that, and sometimes the side effect of it. While vaginal, we shifted very fast from intramuscular, though it also had its own side effects, that is itchiness, uneasiness, especially when patient conceives and continues that more than 2 weeks she has to use, that discharge, irritability, itching sensation, and mainly she needs, if she is a working woman, then, and if we have advised twice a day, it may be little difficult. But Vaginal, why we all loved it. If you see 1 hour after application, you have seen that it has reached into the cervical region, and within 3 to 4 hours, it has reached all across the uterus. So when you put in a high ep in the vagina, these patients are so scared, especially the embryo transfer patient, that they don't like to put high ep in the vagina. Tell them, more the higher they put it, more better it's reaching capacity to the endometrium. So high up in the vagina is very more important, and they don't have to be scared. Between vaginal and rectal, I think vaginal do have a lot of side effects, but rectal, I don't think I advised anyone or anyone will advise, because the chances of contamination is going to be very high. We don't want enterococcus fecalis or anything causing infections. Yes, the gels, they were very important. Either so vaginally, you have a vaginal oral progesterone, vaginal progesterones, capsules, gels, in all the forms you have it. Now, what does the evidence says? Micronized oral progesterone, maximum plasma level in 1 to 3 hours, poor absorption only 10%, and metabolites have a sedative and hypnotic effect. That is why the oral progesterone, when you give, you have to tell patient, she may feel giddy. While vaginal pessaries, it much becomes very, very easy and less side effects with it. Now, oral dydrogesterone, 20 milligram tablets, retroprogesterone with the good oral bioavailability. That is the best thing. This molecule, there is no degrade in liver. So its bioavailability is very good, has an anti-estrogenic effect on the endometrium, causing secretory transformation. It is effective for luteal phase support in IVF. Though this is an old study where they said more RCTs are required, we have now RCTs. Relatively retarded, these were the few people who were arguing in 1990s and all, but now we have thought of changing it. Vaginal as effective as intramuscular as well as oral. Yes, the conclusion is true. Vaginal safer and more patient-friendly than intramuscular? Yes. This is about the micronized progesterone oral. Now, oral versus intramuscular. This was a prospective randomized trial, 50 milligram of intramuscular compared with 600 milligram of micronized vaginal progesterone by one group, while the other group has discussed oral dydrogesterone and say it is equally compatible for a pregnancy rate and a live birth rate. But more than that, the other systemic studies which has come, where 8 RCTs, more than near 4,000 patients, the conclusion was, this is by the ISOC, oral dydrogesterone is as effective as micronized vaginal progesterone in an ART cycle. And it is a good option when it has a similar risk, reduce the cost, and probably more compliance with the patient. So the unique structure of dydrogesterone, and that is why it gives an enhanced oral bioavailability. So high bioavailability. Second important thing is, at a dose 20 times lower than the micronized progesterone, there is an endometrial transfusion because we give only 20 milligram. Minimum side effect and high selectivity for a progesterone receptors. And that is why it helps in, it is also immunomodulator. It increases the PIBF production. It reduces NK cells and other interleukins, which are causing Th1 immunological shift. So we all know that for an implantation, we need a Th2 immunity, while Th1 immunity is seen when you have a lot of NK cells or the wrong interleukins, and mainly in patients of endometriosis, adenomyosis, where we can think of giving even the I transfer GnRH, causing them amenorrhea and asking the shift of Th1 to Th2. So this is very important. Why dydrogesterone is taking the market? Because it's not only the progesterone, not only implantation, but it is also immunomodulator. And because of that, it has gone very high. Inactivated natural killer cells increase risk of IVF failure. This, we all know that uterine natural killer cells, which are more in a unexplained infertility or the endometriosis, adenomyosis, this dydrogesterone has proven its immunomodulator role again and again in various. Now, comparison of delivery rate between oral and micronized vaginal pessary. They have done, this is a very interesting study where they divided patients into two groups, and patients were on an antagonist protocol, a micronized 600 with the oral 20 milligram, and they found similar results. P-value was significant. Both were also in India. I think Dr. Amit Patke has done a very interesting, this thing quite nearly 15 years ago, 2007, where he has proven dydrogesterone. They have given in group 1 long protocol and not at risk of OHSS. Group B, long protocol with the risk of OHSS, and group C, those in a donor oocyte program. And what they found was oral dydrogesterone was superior, giving higher results in all the three groups. Lotus 1 trial. We all know about the Lotus 1 trial, which was published in 2007, and it was for an oral dydrogesterone versus micronized vaginal capsule. While Lotus 2 trial was with the micronized vaginal progesterone gel. And in both the trials, they have shown that oral dydrogesterone is safe, equally effective, tolerability, and not less in efficacy. So if you see another interesting article, they have taken group 1 with the 50 milligram intramuscular. Why I have taken? They studied all the three forms: intramuscular, oral, and micronized vaginal. They have done all the three, and what they have found was clinical pregnancy and live birth was not significantly different in dydrogesterone, vaginal, or intramuscular group, saying that anything is good. You see the side effects with the patient, or the patient's compatibility, or the patient's willingness to take the medicines. This is another beautiful study. What they did, they did only vaginal progesterone in one group, oral dydrogesterone in another group, and they have given along with oral GnRH analog, as I told you, on day 6, and then they have combined oral dydrogesterone with SCG, 1,500 every 4 days. And they found that oral dydrogesterone and gonadotropin alpha or SCG can be more suitable option compared to the vaginal. So all these three are good. Oral is good, this is good, this is good than the vaginal progesterone. I don't know whether it was a biased study, but it was said like that. Now, subcutaneous progesterone versus, because subcutaneous progesterone, I used a lot, maybe pre-COVID pandemic era. Why I started using it was naturally intramuscular was giving too much of pain. Why I stopped is few patients used to give tremendous reactions, itching on the site of injections, and that's why I stopped it. But there are 2 RCTs with 1,500 patients, and what they have done is subcutaneous versus micronized vaginal, and they said there is no statistical difference. So if you want to give subcutaneous, you can think of giving. I think that, to my knowledge, only one company is available with that. Now, when we think about progesterone giving, now we understood oral, vaginal, intramuscular, subcutaneous, all the form. What is the optimal dose I need to give? If you see optimal dose, no current consensus on minimal mid-luteal progesterone level. There is no consensus. How much it should be? 10, 12, 15, 20, how much it should be? I need to have that consensus first before I say this much value one should be avoided. Optimal dose of a high progesterone is still, that's why, not opted. And on an average, what I remember, DeBroy's very 1996 one study, which they measured every 2 hourly or 4 hourly the blood sample, and they have found that if the value goes about 10, maintain if it remains, that should be enough. So overall, they thought that 600 should be the dose needed. That is what they have. And that's why we give a 400 twice a day, that is 800 milligram. SCG for the luteal phase support, how does it justifies? One, it indirectly support by stimulating the corpus luteum, number one. It increases both estrogen as well as progesterone. It has a local paracrine and autocrine effect, very important. And concentration of a placental protein 14, integrin, relaxin, all they increase, they all favor the implantation. It also helps in the increase LH receptors in the endometrium. Now, what is important is it also causes neoangiogenesis in the endometrium, which is very, very important, of no use in patient when if there is an ovarian LH receptor or poor follicular development, you cannot give. By working on the corpus luteum, if your patient don't have a good corpus luteum, then naturally SCG probably may not work, and you may give it directly estrogens and progesterone, the byproducts from corpus luteum. But always remember one thing, when you think about SCG, it will give a OHSS to the patient. So think which patients you want to give. So SCG for the luteal phase support, there are several RCTs which has shown a good ongoing. Drawback of OHSS is going to be very, very important. And that's why we all have moved for a progesterone plus estrogen. And when we say about estrogen, they say there is no advantage. When no beneficial, though there are certain studies which says yes, E2 may be. So you can measure the E2 value, and if you find that it is low, you might as well add low dose of a estrogen. Otherwise, it has no. Now about the GnRH agonist, as I said, it is only for ART cycles, not for IUI cycle. 0.1 milligram of agonist is given on day 6 of a pickup. And what this does is it increases the luteal phase serum SCG value, E2 value, progesterone value. And they are study which shows that the GnRH agonist, which you give for a luteal phase support, has increased the clinical pregnancy rate and a live birth rate. So the 6 RCTs with 2,000 total patients, and they said that there was a significant improvement. So GnRH, other studies, again, how does this GnRH on day 6 will work? One, after embryo transfer in a fresh cycle, to enhance the embryo development potential through a direct effect on the embryo. So they believe that the embryo also can be, LH can directly have an action on the embryo itself. Also, they say that uterine receptivity and the corpus luteal function. Of course, as I told you, estrogen, progesterone from corpus luteal, you need to have a good LH. And also, they say that it works on the endometrium. Justify its use in cases of unexplained failure related to corpus luteum deficiency in both natural and artificial cycles. So it may help by causing a neoangiogenesis. Is luteal phase different in a GnRH agonist trigger than the SCG trigger? Of course. You all should know that when we give a LH as a trigger, that may be because in an IUI cycle, patient has 3-4 follicles and you are worried about this. You just want to release those LH oocytes. Then naturally you can give, instead of SCG, the LH surge. But then the action of LH is just 36 to 48 hours. Its half-life is very small. So you definitely need to give a luteal phase support for this patient. While in SCG, its half-life is long, it helps to rescue the corpus luteum and maintains the luteal function until the placental steroidogenesis. So when you give a LH as a trigger to avoid OHSS, always remember you need to give a very good luteal phase support. Those patients, this is another GnRH agonist, poor outcome. When you give a SCG trigger, you have a better outcome. And obviously that was because the luteal phase was not very well supported in the GnRH agonist trigger. How to rescue the luteal phase when GnRH triggers is directly. Either you give a product, that is the estrogen progesterone, or you give a low dose of SCG. You are giving a LH because you want to avoid OHSS. So you can't give a SCG full, but 1,500 unit you can think of, or you can keep on giving. I think majority of the people believe in giving intensive steroid support, especially in IUI cycle, while in an IVF cycle, rescue SCG dose is also given. They supplement one bolus of 1,500 SEG on the day of a pickup, in addition to standard progesterone and oral estrogen. So to rescue the luteal phase, and that's how you can achieve the normal reproductive outcome. So personalized luteal phase support, there are various protocols which come. You can give a self dose of 3 doses of 500, 1, 2, 3, 3 days interval. It may be safe and sufficient. Some use 1,000, that may be sufficient, or you give a recombinant LH. Now remember one thing, if you want to give a recombinant LH, it is so damn expensive and the dose needed is so high. It comes as a 75 IU and your dose need is 10,000. So obviously no one gives recombinant LH for the luteal phase support. The third option, how to rescue, is freeze all. Just don't bother. Freeze all and then do in a subsequent cycle, either natural cycle or with the hormone replacement therapy. That's how you can think. Luteal phase supplementation in gonadotrophin releasing. Again, there is an American approach and a European approach. What American approach? Daily intramuscular progesterone and then 0.3 milligram of transdermal estrogen progesterone. And they monitor the estrogen and progesterone on day 3 and day 7. And if the dose, they find the level is below 20 nanogram, they will give a 75 milligram, dose is increased. The patches also, if they find that the E2 value, they have to maintain about 200. While the European people, 1,500 SCG is administered 35 hours after the agonist trigger, that is at the time of OPU, and followed by the standard luteal phase support. That's, I think, most of the people will love. What about the adjuncts? These are the so many adjuncts, including steroids. I have not written, it's written prednisolone. There are so many adjective. Does these all adjective helps? Of course, along only aspirin and low molecular weight heparin, I would like to say, has an evidence base, especially in the patients who are immunologically positive, antiphospholipid antibodies positive, or those with the thrombophilias. They can think about this, while other one need to be thinking about sildenafil or steroids. There are few publications which has said steroids given from the day of a transfer for 7 days, it helps. I have no idea about it, but aspirin and low molecular weight heparin. I think low molecular weight heparin, even in immunological positive, we start once we see the cardiac heartbeat, and aspirin, you can start even preconceptional. Now, when to start the progesterone? There are various ways. Administration of progesterone before oocyte retrieval. Please don't do that, because then you are causing premature secretory changes. And then endometrial implantation window may get preponed. So don't start on before the oocyte retrieval. Majority of the people will do from the day of a oocyte retrieval. But if you see the studies where they have done the luteal phase support after 6 days of a oocyte retrieval, that is, if they are doing probably the blastocyst transfer, next day they have started, they found decreased pregnancy rate. But if you start either on the day of a oocyte retrieval or 24 to 48 hours after that, it has no difference, because probably SCG, which was given for the trigger, has also helped in inducing the progesterone formation from a corpus luteum. So usually from the day of a oocyte retrieval, if you are starting the fresh transfer, you should be doing. If you are doing even blastocyst transfer, don't wait for the transfer and next day of a transfer, you should not be. Now, once we understood from the day of a pickup, or those who are for a IUI cycle started from the day of IUI, how long I will give? Usually it is given for 8 weeks, because we believe that by 8 weeks, the placenta takes over, and majority of those that ASR guidelines, those say there is no proven role of adding progesterone or SCG once the pregnancy is established. So you have seen the cardiac activity and all, believe that there is no role of it, no benefits after the first ultrasound. Many other studies have said, while they are saying there are certain studies, they say in a non-ART cycle, beyond the time of expected menses, there is no, that is 2 weeks after ovulation, there is no. But usually And I also do give till 8 weeks of pregnancy, the progesterone support. And when they have asked worldwide, this was a beautiful survey, which progesterone and how long you will give. But this survey was done in 2012 when the Lotus trials, first Lotus trial happened in 2017 and second subsequent to that. So oral dydrogesterone was not so well proven. So I think if today this worldwide survey, if we take it, then I'm sure the report may come as an oral progesterone only drug. But the duration, 72% people have said till 8 weeks of pregnancy, they give the luteal phase support. So friends, to take home the message, in controlled ovarian stimulation, luteal endocrinology and endometrium is complicated by the possible effects of a pituitary downregulation with GnRH analogs and use of SEG or agonist as a trigger. Endometrium is always subjected to this altered endocrinological environment because of the supraphysiological steroid levels, which will cause impaired implantation. And luteal phase support is essential in all ART cycles and those non-ART ovulation induction where gonadotrophins or the gonadotrophin analogs were used. So I think I have cleared many doubts. Progesterone level, how much you should be expecting, more than 15 nanogram, though few people expect it above 10, they say is sufficient, and few believe in having 20. Luteal phase support improves pregnancy rate in IUI gonadotrophin and not in natural. Significant effect in favor of progesterone for luteal in ART cycle. Addition of estrogen in a fresh cycle doesn't give any beneficial effect. SEG or SEG plus progesterone, higher risk of OHSS should be avoided. Addition of agonist on 6th day of a pickup, it helps and it should be given, and no evidence of favoring any specific route or duration of admission. Intramuscular, intravaginal, or the oral, all they are equally good. That is what, as of now, the evidence says. The oral progesterone is nowadays highly recommended because it has been proven that it is easier to one tablet in the morning, one tablet in the evening. So compliance is better. And that's why they have been using it. So it is the task of the reproductive medicine specialist to individualize luteal phase support according to the patient characteristic, her age, her stimulation protocol, her need and desire, and the type of a treatment you are giving. The greatest indication for individualization of luteal phase is following the agonist trigger in a high responder in order to tailor the luteal phase support to the patient, because you have undergone luteolysis and you have given GnRH agonist because you wanted to avoid the OHSS. And that's why it was important. I hope I covered a lot in last 50 minutes, the entire luteal phase support. If you have any questions, you can always get back to me anytime.